Thank you, Anita, and it's always a pleasure to work with GTBI. I am going to get started. If you have questions, please put them in the chat or just break in. I can't see those, so Shweta and Anita are going to monitor that for me. This is the brief outline of our talk today. We're going to look at the different tests for TB infection. And in the United States, it's really the tuberculin skin test and IGRAs. And there are two types of IGRAs, QuantiFERON Gold and T-Spot. And then we're going to move into some clinical scenarios trying to use and interpret the tests. And then we'll have a few take-home messages at the end. So I think the first thing to remember is the important basis of how all of our tests for TB infection work. Presently, none of the available tests check for the actual presence of the TB organism in the body. What they're doing is they query our immune system to see if the immune system has been sensitized to antigens that are contained in TB mycobacteria. And thus, I want you to keep this fact in mind as we go through, because if the immune system of the person you're testing is not optimally functional, the test may not be accurate or may not be interpretable. You'll understand what I mean as we get deeper into this, but it's just an important concept to remember. So, testing for latent TB infection, there's essentially two types of tests. The tuberculin skin test that you see on the left-hand side that probably everyone's fairly familiar with, I would think, or actually more recently, maybe not. It's an in vivo test. The interferon gamma release assays, or IGRAs, are actually a class of tests, two of which are approved in the United States. And these are in vitro tests, where the blood is taken out of the body and the test is actually done in the laboratory. A lot of times people think that if it's done in a laboratory, it's much more precise. But we're going to talk about that as we go along, what the problems there are as well. So let's just take a quick comparison of the two types of tests. The TST, usually referred to as the PPD or the MAN2 test, is what's available in the United States. But there is another WHO approved skin test for tuberculosis called the C-TB test. It actually only uses the antigens that the IGRA uses. So it may be more specific. Not sure if it'll be coming to us ever, but it's being used outside the United States. Now, with the tuberculin skin test, this does require 2 patient visits, one to plant the test, and then around 2 days later to read the test. It requires expertise in both planting the test and in measuring the test. It is remarkably inexpensive, with a test averaging about $1. But in the United States, there's been shortages of tuberculin intermittently for the last number of years. There are false positives and false negatives with the tuberculin skin test. So let's move over to the IGRA. What has always been stated, which bothers me a little bit, and I'll tell you why, that's why the asterisk is here, is that this is a one-patient visit test. But I always say it's a one-patient visit test to obtain the test and be able to run the test. But you actually, whenever we do any test, we want to circle back to the patient and give them the results and explain it to them, what it means. And so I've always sort of bristled a little bit at this idea that it's only a one-patient visit test. It might require a phone call, might require a televisit, something, but it requires a second interaction to close the loop. The expertise for IGRA is different. It requires expertise in both phlebotomy and in the laboratory methods. It is much more expensive than the tuberculin skin tests, and there are false positives and maybe false negatives on that side too, okay? And please remember, neither test distinguishes between infection and in disease. In TB disease, both tests may be negative or indeterminate. Okay, this is just really the schematic of, on the left, it's the tuberculin skin test. So you're essentially taking a mycobacterial slurry, injecting it in the arm, and the white cells will produce gamma interferon and be attracted to the area where you've injected the tuberculin, and that causes a lump that's measured. The difference on the right is in the lab for an IGRA, blood is taken, okay, and it either goes into an ELISpot test or an ELISA test. It actually is only stimulating the white cells to specific TB antigens, really ESAT6 and CFP10. I don't think the new version of QuantiFERON Gold has TB 7.7. And then the test results are read. In terms of an ELISpot, it actually is the number of white cells that are producing gamma interferon in the cell plate. In a QuantiFERON, it's the amount of gamma interferon that's being made in the tube. And that's really the only difference. One's in the person, one's in the tube. So let's talk about tuberculin skin testing. Okay, to do a tuberculin skin test, you need to do an intradermal injection of the tuberculin material, a specific amount, it's 0.1 cc's. This simulates a delayed type hypersensitivity response that's mediated by the T lymphocytes. And in patients with prior mycobacterial exposure, there'll be an area of induration at the injection site within 48 to 72 hours. Just wanted to point out some of the important words here that I want to be sure we all get. It causes induration, okay? I would always joke that with my medical students as I was training them, that actually the best person to read a tuberculin skin test is someone who actually may be vision impaired, because you don't want to be taken in by any redness, any erythema. For example, over the last 35 years, I've had so many tuberculin skin tests that I get very red at the injection site, but my skin test is still negative because there's no induration, okay? The optimal time to read the skin test is between 48 and 72 hours. Large indurated skin tests can be read later than 72 hours, but you can miss small skin tests. So it's really within this time frame that you want to be able to read. Okay. I always say, oh, the Mantoux skin test is a two-step process. And people, again, my medical students would say, oh, yes, Dr. Carter, I understand that. The patient comes once, then they come 2 days later. That's not what I'm talking about. I think it's a two-step process for the healthcare provider who's doing the testing. The first step is placing the skin test and doing a measurement of the induration that's recorded. Then the second step is to do the epidemiologic risk assessment so that you can assign a result to that size of induration, whether it be positive or negative. That risk assessment includes the risk of that patient having been exposed in the past, as well as the risk of developing disease if infected going forward. So two-step process, which is one doing the test and then one interpreting the test. Okay. Again, how do you read the TST? You measure it at 48 to 72 hours. Induration, not erythema. You should record it in the millimeters, not record it by the interpretation. And if you notice, the reading is being done in the horizontal axis. Okay, so it does take some training to do this, or some practice. Okay, here's that second part of the process, which is your interpretation of a tuberculin skin test. The interpretation depends both on the risk that patient has for TB infection, as well as the risk for progression to active disease. So there are three cutoffs. in measuring, in interpreting a tuberculin skin test, okay? 5, 10, and 15. So a 5 millimeter skin test defines a positive cutoff for anyone who's HIV, living with HIV. When you're doing a contact investigation, so you're testing people because of a known recent exposure, okay? People who are immunosuppressed, TNF alpha inhibitors that they're already on, chemotherapy, organ transplantation, or here's a common one, prednisone or glucocorticoid long-term treatment, okay? 10 millimeters, if you notice, I jumped over the abnormal chest x-ray, consistent with old healed TB. I think this is a sort of thornier part to think about. We'll come back to that a little bit later, I think. Greater than 10 millimeters is actually, here's where the conditions that change your risk for progression to active TB disease really come in. So patients with hemodialysis, patients with silicosis, certain malignancies, diabetics, malnutrition, IV drug abusers, jejunal bypass. These are all conditions that increase the risk of progressing from TB infection to TB disease if you are infected and have this condition. So we want to be able to capture these individuals. Capture is not the right word. Sorry, that's not the right language. It should be find. Okay. Now, if you work in a setting where TB is common, then in fact 10 millimeters would be the cutoff. Now, in fact, it's very interesting. For example, all epidemiology is local. Homelessness has always been considered one of the risk factors for TB infection in the United States. But let me just tell you, my specific epidemiology in Rhode Island is that we don't have homelessness-related TB. We've had a lot of data over the last 25 years and only had one case of TB in our homeless population. So for us locally, that really is no longer a risk factor. So I think sometimes you also do have to think about your own local epidemiology in putting people into these classifications. Foreign-born from countries with high incidence TB, that would be a 10 millimeter cutoff. Another question I always get, well, oh my God, how do I, what countries have high incidence TB? It's really easier to think about the negative. It's anyone who's foreign born, who is not from Canada, Western Europe, Australia, New Zealand, and pretty much everybody else, maybe Japan. Greater than 15 millimeters are healthy individuals who have low likelihood of true TB infection. And we would wonder, in fact, in the era of intention to screen is intention to treat, screening people who are at very low risk is probably not part of our usual practice anymore, but there are certain times when you really do still screen. There are screening programs for people who are really not much at risk, such as individuals going to college. Many colleges, because of their congregate settings, will require tuberculin testing prior to matriculation. But remember, there's 3 categories, and your defined cutoff is based on risk of infection and risk of progression. This is I want you to remember this because we're going to think about this as well in the IGRAS. Okay. Okay, let's talk about some of the confusing terminology and use of tuberculin skin tests. Let's talk, what we're going to start with is the booster phenomenon and conversions versus a true conversion. What is this booster response? Okay. Well, remember I said that tuberculin skin tests do not actually test for the presence of the TB organism in the body, they test the immune system. And if the infection is in the distant past, the immune system can begin to forget or find that they needs a stronger antigenic response to remember that infection. I tell people it's like when I run into somebody that I went to grammar school with, which is now a long time ago, sometimes I need to talk with them a little bit and then I'll remember, oh, yes, you're Ginger. I sat next to you in third grade. Think of it that the immune system works the same way. So if the infection was in the distant past, a two-step skin test may be necessary for the antigenic stimulus to be able to be recognized. So what is this? This is done usually in persons where there is planning for serial testing, such as in healthcare workers. And so after the first skin test is negative, if you are checking to be sure they are not infected and verifying in the distant past and verifying baseline, then you repeat a tuberculin skin test 1 to 4 weeks after the initial negative skin test. The first skin test negative, the second skin test positive. This actually suggests that the patient was infected in the very distant past. Okay. And it's important for serial screening so that, for example, a healthcare system can verify that there's not ongoing transmission in their facilities when they do annual testing. Now, conversion. I have to say, I've never used this very much in my own practice, but the CDC does have old guidelines that demonstrate that, say, for example, I was skin tested 5 or 6 years ago. My skin test was 3 millimeters in size, and I'm undergoing a second skin testing now, just for not because of any known exposure, but just because of either workplace requirements or healthcare requirements, such as I'm going to start a biologic agent. Then an increase in induration of greater than 10 since the previous test suggests that I've been infected since the previous test. I'll just have to tell you, I've never found this that useful because it's often very hard to find the true size measurement of the old skin test. Okay. But if you're going to talk about conversion of a skin test, that is where what you're talking about by definition. Remember, serial PPDs will not lead to a false positive PPD. Okay. I really, at one point in my life, my head nurse couldn't figure, in the TB clinic, couldn't figure out. I was traveling so often for doing different grants in Kenya and working in the TB clinics there. She just said, we're just going to put you on the 3-month plan. And so I would have a skin test every 3 months. So I've had literally hundreds of skin tests in my life. Serial skin tests do not lead to a false positive PPD. Okay, if there's induration, it means you've been infected since the last skin test.
Hey, Jane, there's a question in the chat.
Sure.
Is there a specific age that's recommended for the booster test, or should this be determined if it needs to be performed?
That is such a good question. I have to tell you, in the literature, I've never seen a specific time period. I've always thought about it as this is something that usually you would think about maybe 1.5, 2 decades of previous exposure. I think of doing a 2-step testing if, for example, an adult is healthcare worker is now entering the workforce after all of their training. Okay. And could they have been, and they were born in a high incidence country as a child, something like that. Now, I will tell you, within my own hospital system, I see the employee health recommending 2-step or booster testing for 15 and 16-year-olds who are volunteering. That just doesn't make sense to me because not enough time has passed. So unfortunately, I don't think there's any good data, and you have to sort of think about a reasonable um, time point. I think about, am I worried about an adult who was infected in childhood, or I am worried about an elderly patient who might have been infected in their early adulthood? So usually I'm thinking about 20 years or more. In healthcare facilities, they usually just have a policy that everybody gets a two-step. Hope that was clearer. Okay, now let's talk about what people would call false positive tuberculin skin testing. Now, remember that tuberculin slurry that we put into the arm was a slurry, and it actually has cellular components of the mycobacteria in it, and that has components that are not only specific to Mycobacterium tuberculosis. There are 100 different mycobacteria out there. Okay, the most commons being BCG vaccination, which is made from Mycobacterium bovis, or Mycobacterium avium intracellulare, which is in the soil around all of us. Or again, I live in Rhode Island. We have Mycobacterium marinum in our Narragansett Bay. Okay, so that's why it's important to do that risk assessment so that you can specifically assign the induration to the right category. BCG is our thorniest problem for two reasons. Okay. One is, two reasons. One is that it is difficult to predict the BCG effect upon the tuberculin skin test because usually that immunity will wane with time. Okay. So when I started out in the TB world 35 years ago, when we didn't have IGRAs, we were always taught greater than 10 tuberculin skin tests in a BCG vaccinated person, if the BCG was greater than 5 years ago, should be considered true TB infection. That's probably not true. The effect of BCG on the tuberculin probably depends upon which strain of BCG you got, because BCG globally is not like, say, a polio vaccine. If you get polio vaccine or smallpox vaccine or hepatitis vaccines anywhere in the world, it's the same vaccine. BCG is a live vaccine that actually was distributed to research labs in the early 1930s, and there's been genetic drift. And so the BCG given in Eastern Europe is slightly now different than the BCG that's given in South America. And so those have different immunogenicities on the tuberculin skin test. So this is the advantage of an IGRA over a tuberculin skin test. I think you can still interpret very large tuberculin skin tests in the face of a BCG. And if you're trying to figure out whether the patient actually had a BCG, the BCG vaccinations almost always scar, and there'll be a scar on the upper lateral forearm, or in some countries, the vaccination is given in the hip for young girls. If you don't see that and just still want to verify, you can always go to the BCG Global Atlas to see where BCG is given, but it is the most common vaccine given globally because it does protect small children from progressive disease if infected in high burden countries. False PPDs can also be because of misreading. The reading should be done horizontally across the forearm, and you read induration, not erythema. Okay, what can lead to a false negative tuberculin skin test? Okay, if the patient's immune system doesn't work, okay, that can be an HIV infection, steroid use, malignancy, ongoing use of TNF alpha blockers, live viral vaccines given within the last 6 weeks, a viral infection within the last 6 weeks. Okay, all of those can lead to a false negative skin test. Any active infection, including active TB, can suppress the skin test because your immune system is too busy fighting off that infection because, and so can't really respond to the small antigenic stimulus of a tuberculin skin test. And remember, it takes between 4 and 8 weeks for your immune system to become sensitized so that a skin test, a tuberculin skin test, can be positive through recognition of your immune system to the antigen. Also, improper storage or improper administration, improper reading are all reasons for negatives. Okay, so after that survey about tuberculin skin tests, let's go over to the interferon gamma release assays. And we're going to spend most of our time on QuantiFERON Gold because that's what's most commonly used in the United States. This is an older slide, and so you see there are only 3 tubes in that top left corner. Now there are 4 tubes that are actually in QuantiFERON Gold plus. There are actually 4 tubes, but this is the steps, all the steps that have to be done to run a QuantiFERON Gold. And so that's the purpose of that slide, and we're going to come back to why I show you how many steps there are in just a minute. Okay, well, here is the advantage of IGRAs over the tuberculin skin tests. Here is a listing of some of the most common mycobacteria that people come in contact with in a day-to-day basis. And you can see that eSAT6 and CFP are present in the Mycobacterium tuberculosis complex, but are not present in BCG substrains. Now, of note, take a look over on the right, though, M. kansasii, M. marinum, M. silgai do have eSAT6 and CFP. These are infections that are much rarer, but they actually can elicit a positive gamma interferon response. Okay, but this is the advantage of an IGRA over a TST because it takes out that whole issue of BCG. And just again, outside the United States, the CTB test actually only looks at these antigens. So it's a skin test that actually is much more specific. Okay, well, I'm not sure how many of you have drawn these tubes, but there are 4 tubes that are drawn in a QuantiFERON Gold Plus. Okay, why are there 4 tubes? Well, there are 2 controls. The mitogen, this purple tube, and the nil, which is the negative control, this gray tube. Okay, and then the antigens are in the TB1 and the TB2 tubes. That's the green and the yellow cap. Well, why do we need these controls? These actually are also very useful in an IGRA. So the nil control, let's start, we'll go from left to right. The nil control, this gray one, this adjusts to see for background gamma interferon. The nil tube should be almost 0 because the white cells in patients should not be being stimulated in a day-to-day basis to make gamma interferon. If there is a high level of gamma interferon in the bloodstream at baseline, then in fact, the remainder of the test becomes void. Okay? Now, mitogen, okay, over here in purple. This is checking to see if your immune system is working today. Okay, this tube doesn't have any TB antigens in it. It has another antigen that all of us would recognize from the environment. And this is to check to see if the patient's white cells can actually produce gamma interferon. So when this test is done in the lab, the purple tube should have a high value, and we'll show you that in a minute. The gray tube should have a very low or 0 value, And it's only if these two tubes are in those correct zones that the TB1 and the TB2 antigens are looked at. Okay, so if the mitogen or the nil controls do not work, the test is reported as indeterminate. It means the test didn't work. We can't interpret anything further. And so that is an advantage because, for example, in a tuberculin skin test, if it's 0, you don't really have a control that tells you that the immune system is working. You have to depend upon your epidemiologic history. The patient doesn't have HIV, the patient's not on chemotherapy, the patient has no reason to think that the immune system doesn't work. Okay. Now, how are the tests reported? Okay. The results will be reported in international units per ml. And the lab is supposed to give you both the numbers, that's the qualitative report of the test, and then an interpretation of the test, whether it's positive, negative, or indeterminate. It is positive if either the TB1 tube or the TB2 tube minus whatever gamma interferon was in that nil control is greater than 0.35. Okay, and a negative result is if the tube 1, tube minus the nil is less than 0.35. I'm saying that because I want you to look at this. Oh my God, this is a true binary cutoff, isn't it? We're going to come back to that in a minute because we did this whole thing with the tuberculin skin test that we needed to do this risk assessment. Okay, does this mean that the IGRA does not need a risk assessment at the time that the interpretation comes back? You can tell where I'm going with that one. Again, an indeterminate result is if the mitogen tube is negative, then that patient is immunosuppressed. If the nil tube is too high, there's high background noise, so all bets are off, and the test cannot be reported as positive or negative. Okay. So can you get false negatives and false positives for a QuantiFERON Gold Plus? Okay. You could get a false negative if you do the QuantiFERON Gold in the window period before the patient has had time for their immune system to be sensitized. I'm not sure that we should call that a false negative, but just highlighting the point that if you did it in that window period, the test can be negative while the patient is really converting their skin test. Okay. False positive, remember that M-Kanzasii, M-Sulzi, M-Marinum can actually be positive. Okay, M-Bovis can be positive, but not BCG. So these would be infections with a mycobacterial that's not MTB. But look at this. I've got this big thing that says analytic issues. What does that mean? Okay. So let's talk about that a minute. So remember that a QuantiFERON Gold Plus is a laboratory test. So it depends upon phlebotomy. Was the skin cleaned well enough at the point of needle insertion? Were the tubes filled appropriately? In QuantiFERON Gold testing, the test begins in the test tube. So the phlebotomist is actually trained how to shake the tubes non-vigorously. How long did it take for the specimen to get transported to the lab? Was it over a bumpy road? Was the incubation period for the test correct? And then there are batch issues. So problems in any of these analytic steps leading to the laboratory result can lead to a false positive, but these false positives are usually very low results. So that takes us to that bottom right red portion on my slide. A low result so that the TB1 or the TB2 tubes being between 0.35 and 1 need to be interpreted in the context of the patient's risk profile. Take a minute to think about that. That is just like thinking of the 5, 10, and 15 millimeter cutoffs for a tuberculin skin test. This is why it is so important for the laboratory to report to you both a qualitative number and the quantitative number and the qualitative interpretation of the test.
Jane, can I
Pause.
stop? There's a question in the
Yeah,
chat.
I was about to pause because I was waiting for the question there.
So it says, can recent or frequent PPDs cause immune response on the IGRA? Is there any time you should wait to draw the IGRA after receiving a PPD?
Oh, Anita, I thought you told me that these are people who are just new to their TB world. That is a very good question, and it's a very important question. There are reports that if you do a tuberculin skin test and then you follow it almost immediately with an IGRA, that you can get these type of low positive results, okay, on the IGRA. So you do have to think about the timing of doing serial cross-testing, I call it, which is, okay, somebody got a PPD, they don't believe it, you're searching for a different answer, there's some reason why you want to go to the other side. But so yes, there are reports of low positive IGRAs if you do it in a very short time period after the tuberculin skin test. So, if it's not an urgent matter, then I usually would wait a number of weeks, 6 to 8 weeks. I can't remember seeing in the literature a specific time period. But again, if the IGRA is in the very high levels, that's why it's important to look at your quantitative number, then I think you can still interpret a quantiferon that just followed recently on the tail of a tuberculin skin test. Did I answer that okay, Anita?
Yeah, I think would you also in this particular scenario, would you also want to consider the person's risk?
Right. It's a risk. It totally becomes the risk assessment. Now, I can't imagine that you would do a second quantiferon gold after tuberculin skin test if you're doing a contact investigation. If you are, you might be trying to tease out maybe this might have been something like a healthcare worker who was BCG vaccinated in the past and had been told for years that this affected their tuberculin skin test. That is a reason you might be able to delay this a little bit and then do a quantiferon so there's no question about the issue. But you're right, you're always thinking about it in the context of risk. If I miss this immediately, and yeah, I think I answered that.
And somebody asked a follow-up to that is would it be the same for a T-spot?
Yes, it's the same for both. The principles are all the same. I would always ask, why are you doing a second test and crossing over? I usually only cross over to a different type of test for usually very specific reasons.
Right, and the person who asked the question said that with this particular case, the induration was very questionable and they weren't confident in calling the PPD positive.
Right. Okay. Then if it was part of a contact investigation, you would always opt to TB infection first. If it wasn't part of a contact investigation, the patient wasn't immunocompromised, then you could delay out a little bit and do a quantiferon gold later, 6 to 8 weeks.
It's very nuanced area and
it is. Yeah. Do you know each case is very individual? So for example, if this was a transplant patient and they suddenly had a transplant available to them, I say, we consider this positive, you're going to get treated and let you get off to your transplant. So these are very individualized questions. The T-spot is actually an ELISpot assay, and this is a little bit different than the quantiferon gold. And the quantiferon gold that we were just talking about had a binary cutoff of 0.35. If you notice, the quantiferon gold is reported out into spots. These are literally white cells that are counted, that are turned on to producing gamma interferon. And so it's the number of spots. So greater than 8 is positive, less than 5 is negative, 5, 6, 7 are borderline. So they, in a T-spot, they actually do have a borderline case where they're already alerting you to this idea that you have to think about the risk factors for the patient. Now, a T-spot can sometimes be a better choice than an quantiferon gold if the patient has a low white count, okay? Because this is individualizing the quantiferon gold measurement to the number of white cells, whereas the quantiferon gold doesn't know how many white cells are actually in the sample and is just looking at the absolute amount of gamma interferon that's being made. But everything else I've said about a quantiferon gold applies to a T-spot. I'm going to pause a minute, see if there are any other questions, and I'd like to take you through a couple cases so we can show each other how you think about these. Any other questions out there, Anita? People have said? Nope. I can keep going. Is that all right?
Another question, are the results of an IGRA different depending on being remote rather than recent infection?
No.
Yeah, it can't detect the difference between.
Right.
Yeah.
You can't tell it. You can't, if you're doing an IGRA on me and it's positive, you can't tell if from that test whether I was infected 15 years ago or 4 months ago. Now, just remember, there is that window from the day I inhale my germ to the day that my immune system can reliably tell you that I'm infected. That's a window of about 8 weeks.
Right. And again, I think it comes back to risk, your risk, the day you were infected,
Right.
it might change as you progress through your life, where you develop diabetes later and then yeah. So it can't detect the difference between remote rather than recent infection.
Yeah. Yeah. We need
Okay.
better tests. I hope one of you will go out there and I'll come to your Nobel Prize award. Okay, so let's do a couple tests. So I have one tuberculin skin test example, and it was actually from my experience at the TB clinic in Rhode Island years ago. So I have an 18-year-old gentleman. He was born in Rhode Island, and he's getting a tuberculin skin test because he's supposed to be going off to college soon, and it was read as 11 millimeters. Okay, I'm stopping a minute for people to think, positive, negative, what do I need to know? Okay. He has no medical problems. Okay. So that probably takes it out of a 5 millimeter cutoff. We're in the 10 millimeter cutoffs, but maybe not. Maybe he can be a 15. He's never traveled. Okay. Okay. Rhode Island's pretty low incidence state, so maybe this is a negative tuberculin skin test. He lives in Providence. You would only know that might be important because almost all of our TB in the state of Rhode Island is in the city of Providence. We're a very small state, so pretty much most of the population lives in Providence. And he's second generation US born of Cambodian parents. So at least our local epidemiology is that in our firstborn, first generation young children and adults, their risk of infection, it does seem to be a little bit higher than if they are not first generation born, because they were living in communities with a little bit higher incidence. So I have to think a little bit whether I'm going to use 10 or 15 as my cutoff there. Okay, well, good. His chest x-ray was normal, so I don't have any problems so far. That this looks like I'm still dealing maybe with TB infection. He's leaving on 6-month pre-college tour of the world on a bicycle. I might have to take that into effect as to whether I want to get him started on his treatment now, because is this always a good timing? And then, oh yeah, I wanted to do a physical exam. And he has matted nodes in his supraclavicular fossa. So in fact, this case becomes not even a case of TB infection and worrying about what cutoff I'm going to use, but this becomes a case of possible TB disease. But I take you through those little steps because in each one of those pieces of information that I was peeling back about that 11 millimeter PPD is helping me to decide his risk of TB infection up to this time period and his risk of TB disease if he is untreated at this point. I hope that makes sense. So again, I think this always makes healthcare workers a little uncomfortable, isn't it? Because we like to, we like to think of medicine as a yes, no, black, white, dichotomous, easy to determine where people are in terms of what is happening to them. But in fact, the situation is quite fluid, and there are very many pieces that go into interpretation of a test, even like a tuberculin skin test. But let's actually go over to some IGRA examples, okay? Now, this always drives me crazy. I think it's always a problem when when I'm looking at a result and there's 4 paragraphs to tell me how to interpret it. I'm trying to look quickly over where the result is, where the range is, and I will just tell you the fact that I work in several different healthcare systems, and it seems to me that everybody's lab presents their QuantiFERON Gold results on a different format. So take a minute and become familiar with your lab's format. So the range up here, this negative is not the result of this patient. It's just what's supposed to be the accepted range of the test. Okay. The value here is their interpretation of the test. Okay. Now let's take a look at our numbers. Okay. Look at this mitogen. It's very high at 9.96. Okay, this person's immune system is working very well, okay? Their nil is almost 0.02, so they're not overproducing gamma interferon, okay? So the test for the TB1 and the TB2 can be interpreted, and in this instance, this is a little unusual test. To me, I never see this as, I rarely see this as a 000. It's usually just a small number here, but it means that the white cells in these tubes were not stimulated. This test, the controls are working, so the value is negative. Okay, the interpretation of the skin test of this IGRA would be that it is a negative skin test and the patient is unlikely to be infected. And just look at that. I want you to notice unlikely. Okay. The lab is still telling you that you have to have a clinical interpretation of why you did this test and what else is happening. Okay. Let's look at this one. Okay. Again, your range is up here on this lab. Your range is up here on the right, so don't get fooled that you looked here quickly and said, oh, negative, good, I can just keep going. Here's the value for the patient, this positive. Let's look at mitogen is 5.67, so it's a fairly high number, okay? The nil is very low at 0.31, so the two controls are working, and the TB1 minus the nil and the TB2 minus the nil are all high values. Look at this, they're in the range of 8 point something. Okay, remember we said that the cutoff to define a positive is going to be 0.35, well above that cutoff. This is a positive quantiferon gold, suggesting that the patient has TB infection. But again, I just always think it's funny that there are so many disclaimers on these test results. We're just not used to seeing that usually in labs. Okay. So here, let's take a look at another one, okay? Here, let's do the left-hand one first, okay? We want to look at our numbers. The mitogen, okay, let's take a look. Here's again, this is a different lab, and it takes me a minute to orient myself to see which is which, okay? So here's the at the bottom is quantiferon plus mitogen minus nil. This is 0. Okay. This is the one that should be high and test for your positive control. Okay. At the top is your quantiferon plus nil value, which is 10. Well, this doesn't make sense at all, because the mitogen is usually in the range of 10 and the nil is usually in the range of 0. This just says this test cannot be interpreted any further, and the lab will report this as an indeterminate. Okay. Now I can go through all of the strange ideas of how I thought this happened, but for your clinical evaluation this is an uninterpretable test. Okay, let's look at the one on the right. Okay, this one is, let me take a look. Again, I have to sit and look a minute. Okay, they've changed around. This is a different lab. Okay, they've changed around the order in which they're doing the reporting. Okay, so you have to sort of sort this one out. So let's go down to the third row, quantiferon mitogen value. Look at this. This is a very low value, 0.14. Okay, this patient's white cells are not responding to a normal antigenic response. That defaults the whole test, and it becomes indeterminate. Okay. Now, if you had the result on the right and you're trying to decide what to do next, one possibility would be to say, oh, this patient's immune system wasn't working. And you'd go back and take a look at the patient and say, is there something about his immune system that's going to change? Maybe this was a patient who had an asthma attack, and this was drawn while he was on systemic corticosteroids. When he tapers off of his steroids, you could consider redoing the test after he's had a little period, few weeks, a month to recover his immune system. But if this was a patient who in fact is on chronic steroids for their inflammatory bowel disease, you're not going to be able to change that. So repeating the test is of no value except to, I'm going to say a cynical remark for a moment, to send more money to the company that makes quantiferon gold. If you can't change the patient's immune system and the test is indeterminate because of the mitogen being low, no reason to repeat the test. Okay, the test on the left, I really have no clue what happened here. I almost think they switched the tubes, but the tubes are colored, so I don't know why. So maybe I would consider redoing the test on the left. But those are the reasons why the these quantiferon goals are indeterminate, and it just shows you that you actually, when the test comes through from any specific lab, just take a minute to orient yourself to each of the lines because they're reported differently from different labs. Okay. And then this is just sort of an interesting one that we can take a look at. This was a patient who had a quantiferon gold test that was clearly negative in November 2019. Look, your mitogen at the bottom, very high, almost 10. Your nil at the bottom, at the top is very low, so that you can now interpret your TB1 antigen and your TB2. These numbers are very low, 0.0 something. So this was a negative test. The patient gets another test in 2021. This one is considered positive. Let's take a look at it. Okay, the mitogen is high. Great. The nil is low. Great. We can interpret the test. Well, look at this. The TB antigen is at 0.346, which is going to be rounded to 0.35, and that's what makes this test be positive. Okay, that's very different than the other positive tests that we looked at before. So this is a patient where you go, wait a second, maybe this test was done because they changed jobs. Maybe this test was done because of some other issue that's coming up. But you talk to the patient, they've had no travel, they've had no exposure. This would be a case where you go, is this a false positive? And a test is repeated. And in fact, you can see the mitogens have all been consistent. The nils have all been consistent. And now that TB2 antigen is clearly in a negative range. So when the test is between 0.35 and 1, you have to pause and say, has this patient had risk for being TB infected? Is this a true positive? Okay. So I hope I have convinced you that you don't just look at the positive and negative answer. And in low positives, I want you to do what we always should be doing in medicine, pause to think about what that patient's risk is. Okay. Important take-home messages. Interpretation of the results of a skin test or an IGRA is always interpreted in the context of the patient. There's no gold standard to diagnose TB infection. Pre-test probability matters. So you're always asking yourself questions about risk factors for being infected, risk factors for reactivation, and what are the possible reasons for a false negative or a false positive or a false negative test. And remember, skin tests and IGRAs do not differentiate between latent and active disease. Neither is used to follow response to treatment. After a TB infection and treatment, both should remain positive going forward, so repeat testing is not indicated as it adds little additional information. And intention to screen should always be coupled with intention to treat, and to treat those patients to completion of therapy. I'm going to include this in the slide set because I just think it's a really nice table that goes through the variables of skin test, tuberculin gas, quantiferon, and T-spot. And I'm going to stop. I think I have about a few minutes left for any other questions that have come up. I wanted to acknowledge Dr. Linda Shipton and Dr. Ed Zaweski for letting me use their IGRA case studies.
Thanks, Jane. There was another question related to the first patient scenario presented, the 18-year-old.
Oh, yeah.
Would there be any further tests that you would want or order before treating?
So once I found his matted nodes, then I needed to biopsy his nodes. I think he has extrapulmonary TB. And I put that in there only because I think sometimes we forget about doing a physical exam. We get so excited that we've done the skin test, we've done the chest x-ray, And we sort of forget that 15% of TB has extrapulmonary disease. So in that case, I would have then proceeded to biopsy his lymph nodes, that once I find the lymph nodes, he's no longer a TB infection case to consider. I know that was a lot. Sorry. Thank you, everybody.
Are there any other questions for Dr. Carter? Feel free to unmute and ask your question,
Yeah.
or you could put them in the chat.
Yep. And on the slide set will be my, the first page has my email, so that if you sit there and start looking at those cases again and go, what did she say? Or you don't want to go through the entire recording, you feel free to write. Again, I have to tell you the thing that drives me the most crazy, and I don't know, Anita, if your other consultants mention this, I just wish there was one standard reporting form, but every system I work in has a different form for reporting those quantiferon golds. And so I've just had to teach myself to say, sit down, where are the values? What order are they in? So.
And I think, you know, as Dr. Carter alluded to with some of the questions earlier about when you do two tests and what happens when you have discordant results, and how to approach a low positive IGRA, I think those are all really complicated scenarios. And that's where we would encourage you to reach out to a TB expert available to you within your TB program. So whether it's your state TB consultant or the consultation service available through the Global TB Institute.
Yeah.
I don't see just a lot of positive comments, Jane, about your this being a great review for everyone.
And just to
So
follow that up, Anita, I have to say, I see that I always joke and tell people, once you're in a lane, it's just like on the freeway, it's probably safest to stay in that lane. You know, I think that the most common reason to cross your lane in your TB testing is that people didn't like the result of the first test. So it's often that the most common reason I see for changing is that you did a tuberculin skin test in a patient who's BCG vaccinated, and they've been told for so long that the skin test is from their BCG that they don't want to hear it, and you go to the other test. Again, that's the place where I'd think about the test that you're going to start out with. If they're BCG vaccinated, maybe you should just go to the quantiferon to begin with and just not even have to worry about these cross lane changes.
yeah, I agree. When you start changing, then you invite more. You get more information, but you have to figure out what to do with that information.
Yeah. You have to be careful that you're just not looking for a result that is the easiest to deal with, but that you're actually combining the sets of tests to answer a specific question. Just like the question that came up in the chat, you know, maybe you have a patient who, you know, a chemotherapy, a patient, you know, a young child on leukemia treatment, and he's just been exposed to an he's coming from, I don't know. No, I have to think of how to say it. Say a young person who's getting chemotherapy for their cancer and suddenly needs to be skin tested or screened for TB infection because of job or school. That's a place where you might actually do a quantiferon gold, a T-spot, and maybe a tuberculin skin test all at once, because you're working with an immune system that doesn't work and a high-risk patient, and you're really trying to sort it out. You know, so I think what you're doing when you want to do a lot of different tests, you're trying to actually get more information. But you're right, even among the consultants, we send these around to each other for a consensus statement. Thanks.
Thank you so much, Jane. That really was a great review. So I see that Shweta put the evaluation link in the chat. If you don't mind completing the evaluation, if you have any additional questions, feel free to reach out to us. And we'll include Dr. Carter's information on her slides when those are posted. Otherwise, stay cool and hydrated, everybody, and have a wonderful weekend. And we'll see you all next Friday for the next session.
Okay.
Bye. Thanks again, Jane. Stay cool.
Same to you. Bye.
Bye.